They made a mistake in their picks. Hi, good morning, everyone. This is the last Retina Imaging Conference for the academic year. We'll resume in September. So I'm Jose Polito, and on behalf of the chief at Wills Eye Hospital, Dr. Julia Haller, on behalf of the director of this great Retina Imaging Conference, Dr. Ernan Sivalingam, I'd like to thank the fantastic audiovisual team for all the work that they do week in, week out, rain or snow, to make this possible. Mr. Jack Scully and Mr. Bill Romano and Susan Umfer that sends out those weekly reminders of this. I'd like to thank the fellows for their tremendous work in putting this conference together week in and week out. Doctors Mira Sivalingam, Doctors Jacob Light, and Dr. Ebtin Chalet. They've done a tremendous job. I think we've all learned from them. The great retina colleagues of mine at MAR, Mid-Atlantic Retina, and Dr. Carol Shields that come in so early in the morning to do these. And finally, I'd like to thank all of you that are listening every week and send us your thoughts as well. We all really appreciate that, and we look forward to seeing you back in September. So without any further ado, let's start the cases for today.
Thank you, Dr. Polito. Good morning, everyone. I'm Ebtin Chalet. I'll be presenting the first case today. We're hoping to get through 4 quick ones today. Our first case is a 26-year-old gentleman with a history of poor vision since childhood and referred specifically for evaluation of macular edema in both eyes. Dr. Sivalingam, would you mind walking us through these photos?
Yeah, so here we have a wide field pseudocolor fundus photo of the right eye. Visual acuity is significantly decreased at 2200. Media overall looks clear. Looking at the optic nerve, there is significant temporal pallor and what appears to be cupping here. It's certainly not a normal nerve that you would expect to see in a 26-year-old, but sharp disc margins. Looking at the vasculature, overall looks normal in its course and caliber. Macula overall looks normal. And yeah, I think this looks normal. You have a little bit of a nerve fiber layer sheen. Maybe would expect that to be a little bit more robust in a young person, but it's still definitely there. I don't see any hemorrhages. And again, this kind of highlights the abnormal appearance of the optic nerve, significant temporal pallor, and some cupping here as well. And then same imaging modality in the left eye, again, decreased visual acuity at 2200, clear media. Again, similar findings of the optic nerve. I think more pronounced temporal pallor here. I don't know if that's just a result of this image is a little bit darker, so it highlights it a little bit more. But significant temporal pallor, significant cupping, sharp margin, vasculature looks normal in its course and caliber. Periphery, what's visualized, looks normal. And again, this just shows us more clearly the temporal pallor and cupping. You do have this nerve fiber layer sheen out here along the arcades, and less noticeable here in the macula. Fundus autofluorescence of the right eye. Looking at the nerve itself, typically in a healthy nerve, you would expect a little bit more hypoautofluorescence. So, this looks a little bit hyperautofluorescent to me, possibly correlating to that cupping that we saw. Looking at the macula itself, overall pretty normal hyperautofluorescent signal in the macula, maybe a little bit of an enlarged area of hypo, but nothing obvious. And then the visualized periphery looks normal. I think these are maybe just artifact.
That's accurate.
Yeah, that's his artifact, same. And then same findings again, kind of this more hyper autofluorescent signal here. We would expect this to be darker, and then overall normal pattern in the macula here, and the periphery looks normal as well. Okay, so this is a horizontal OCT through the right eye. Look at the infrared itself. It kind of has this interesting granular hyperreflectivity pattern throughout the entire macula. I didn't see anything obvious on the color that correlated to this. And then looking at the B scan itself, starting with the vitreous, looks like hyaloid is down, which is what you would expect in a 26-year-old. And just going layer by layer, significant attenuation of the nerve fiber layer. You would certainly expect it to be thicker and more pronounced in someone of this age. And then we see these small kind of microcystic changes in what looks like is the inner nuclear layer here. And then maybe some, I don't know if this is just artifact transmission through here, but maybe some subtle changes in the outer nuclear layer, but certainly not as pronounced as in the inner nuclear layer. Good preservation of the outer retinal layers, photoreceptors, RPE overall looks normal. Choroid looks normal. Yeah, and then similar changes here. Infrared, again, you can see the pallor and cupping of the nerve. Similar pattern, this kind of diffused granular hyperreflectivity throughout the entire macula. And then again, significant attenuation of the nerve fiber layer. And then similar, these kind of small multifocal microcystic changes that look like they're confined to the inner nuclear layer here. Outer retinal layers look normal, and choroid looks normal.
Here we just have a cut involving the disc as well.
Yeah. So, I think this highlights really nicely the significant loss of the nerve fiber layer. We can follow it all the way to the nerve, and we see significant cupping. This is not normal in someone this age or anyone. And then this highlights nicely the choroid looks overall pretty normal in thickness. And then you get, I think this is possibly increased transmission due to the loss and cupping here in the optic nerve.
Excellent.
And go back though, and that's also, so you're seeing the lamina cribrosa right here. And that's why, just like you can see in patients that have choroidal atrophy, you can get in autofluorescence, some what appears to be hyperautofluorescence. It's the pseudofluorescence from the sclera. Here you did get it from the lamina cribrosa.
So that's what we were seeing in the autofluorescence. Got it.
And some quantitative imaging.
Yeah, so this is an analysis of the nerve fiber layer. So, looking at the heat map over here, we can see overall very attenuated thickness here. We're down to the lower end. And then important to look at here, the overall volume is significantly decreased and attenuated. Dr. Polito, correct? What is your normal volume here?
With the smaller scan size that you can see down here, if it's less than 0.4 millimeters cubed, that's thin. So this is tremendously thin because it's a volume measurement.
And similar findings in that left eye on the bottom.
And then here we're looking at the ganglion cell layer. Again, severely decreased thickness throughout the area of the scan and significantly overall decreased volume, which is not surprising.
Is that volume of the retina or volume of the ganglion cell?
Ganglion cell.
So for this particular case, I wanted to have more of a discussion of these macular microcystic changes. So broadly speaking, Dr. Sivalingam, what sort of entities do you think about when you look at cystoid changes in the macula?
Yeah, I mean, I think keeping it broad, you can think about, several different categories. So, our typical CME, you can divide those into leaking and non-leaking. This certainly isn't, your typical appearance for like a leaking CME. You have most of these small cystic changes confined to the internuclear layer. Typically with CME, they're more outer plexiform, although they can be in multiple layers. We certainly don't see any subretinal fluid, and the rest of the vasculature looked normal. But you can think of microvascular processes like diabetes, hypertension, medication exposures, and then, more schisis-like changes, which you, again, would more likely be confined to the outer plexiform layers. But, you can think of myopic schisis, degenerative schisis, processes like sniffer, and then more other degenerative processes that you can see in processes like glaucoma and different optic neuropathies, where it's more of like an ex vacuo type effect, where you see these these microcystic changes due to the loss of the actual cells. It's not so much a splitting effect or a true macular edema per se. So I think, looking at the significant loss of the nerve fiber layer and ganglion cell layer with the significant cupping, it looks like, some type of optic nerve related process.
So very nice broad differential there. As Dr. Sivalingam mentioned, all these categories with schisis, we tend to have this splitting out at the level of the outer plexiform layer. It corresponds to microcystoid degeneration of the neurosensory retina. Myopia would be an instance that we would see this, also sniffer. In cystoid macular edema, macular thickening is more what we see, and it's owed to the disruption of the blood-retinal barrier, which can cause leakage within the intracellular spaces, predominantly in the outer plexiform layer, but we can see it in the inner plexiform layer, and as we see in this photo, it can cause subretinal fluid as well. As Dr. Sivalingam mentioned, this could be an exudative process or a transudative process causing leakage versus non-leakage of the CME, which has its own broad differentials. And then with the patient that we have here, the image at the bottom, we're dealing with more what's called as pseudocysts or microcysts. These are localized to the inner nuclear layer, and we'll have a little bit more of a discussion about them here. So regarding the patient's history, he was an immigrant from Africa. He left at a young age. He had had low vision since childhood, did not recall taking any sort of medications, including TB medications, no prior eye issues in the family. The intraocular pressure was within normal limits on our examinations, as well as previously, no history of ocular surgery, no history of deafness or history of metabolic disease, including diabetes. So just discussing a little more about these microcystic changes in the inner nuclear layer. This is a phenomenon that's been described in different entities of optic nerve atrophy. And in this OCT study, they found to be present, always associated with severe optic nerve fiber layer loss. The reason was not very well understood, but the thought was it might constitute a translation of degenerative changes of the Mueller cells in the setting of severe optic nerve fiber loss. Importantly, this may be confused with cystoid macular edema, but unlike CME or true CME, it does not require any sort of treatment. This is a study of these macular microcysts and the prevalence in the setting of mitochondrial optic neuropathies, namely Leber's and dominant optic atrophy. And they found the prevalence to be about 5 to 6%, and there was an association with outer nuclear layer thickening in these optic neuropathies. The other retinal indices, including total macular thickness, nerve fiber layer, ganglion cell layer thickness, were significantly reduced. So the author speculated that there may be a component of vitreoretinal traction contributing to the thickening of the outer nuclear layer, as well as to the production of these cystic spaces. This can also be present in acquired optic neuropathies, and this is a study of patients with different etiologies of glaucoma. looking into microcystic macular edema in these patients, and they found a detection rate of about 1.6% of these patients. This is an example en face image and quantification of a patient with glaucoma in these microcystic changes. They found an association between these changes with some of the glaucoma indices as well as the visual acuity. So in our particular patient, he did undergo genetic testing. A blueprint genetic analysis was performed. It was non-diagnostic, and he's currently in the process of undergoing a more dedicated optic atrophy panel. We're going to move on to case 2. Dr. Light will be taking it on.
Thanks very much. Case number 2 is that of a 40-year-old female who was referred from the Wills ER for retinal pigment changes in the right eye. Again, Dr. Sivalingam.
Yep, so we have a wide field pseudocolor fundus photo of the right eye. Visual acuity is good at 20/20. Media looks clear. Optic nerve looks normal, good margins, no significant cupping. Looking at the vasculature itself, looks overall normal in its coursing caliber. And it has this interesting little abnormal loop of a vessel, but no hemorrhages in the area surrounding. And then attention is drawn to these kind of patchy, multifocal areas of hyperpigmentation along the supratemporal mid-periphery. Kind of have this larger area here with these smaller multifocal areas of hyperpigmentation trailing behind. Again, I don't see any hemorrhages or other abnormalities surrounding. And then the rest of the visualized periphery overall looks normal.
Maybe a little more zoomed in view of some of these lesions here.
Yeah, this is nice. So again, this just highlights these kind of multifocal areas of hyperpigmentation, almost in a track-like pattern here, even trailing back here above the optic nerve, actually in here nasally as well. And then here we have same imaging modality in the left eye. Media is clear, nerve looks normal, vasculature looks normal, and then the visualized periphery looks normal. I don't see, the same type of pigmentary changes in this eye. Yeah, it looks normal.
Yep.
Fundus autofluorescence of the right eye. This highlights those multifocal lesions that we were seeing here. So, significant hypoautofluorescence signal correlating to those areas of hyperpigmentation. And this highlights these areas that were a little bit more subtle in the color fundus photo, this lesion kind of nasal to the disc. But surrounding these areas of hypo, I don't see any, rings of hyperautofluorescence.
Agreed. And again, just to get a little better look at them.
Yeah, this highlights it really nicely. Just hypo signal correlating to those pigmentary changes. And then we have the left eye, overall looks normal kind of hyperautofluorescent pattern of the posterior pole. I don't know if this correlates to anything, maybe an area of pigment change or scar.
It was non-specific, and there was really nothing obvious clinically on exam.
Okay. And here we have horizontal cut through the right eye. Looking at the infrared image itself, it looks overall normal. It doesn't capture that area of hyperpigmentation that we were seeing. And looking at the B scan itself, vitreous is clear. We have, looks like the hyaloid is down here. Good nerve fiber layer, good interretinal and outer retinal layers. Choroid looks normal. And again, normal infrared, macula looks pretty pristine. Vitreous is clear, hyaloid's down. Hello, hyaloid's down here. Nerve fiber layer looks nice and healthy. Good inner and outer retinal layers. Choroid normal. So overall, two pretty normal OCTs of the right and left eye.
Yeah, absolutely. And patient is completely asymptomatic. with this presentation. Again, this was picked up incidentally. So regarding the right eye, what's your differential when you see this sort of pattern of hyperpigmentation?
Yeah, so different kind of entities of multifocal areas of pigmentation. You can think of things like chirpy. Certainly this is pretty multifocal, so we think of, multifocal chirpies or bear tracks. Thinking about the things that are most dangerous, you can also think of a choroidal melanoma, although this is definitely not typical. Choroidal nevus, again, not typical in its appearance. It's very multifocal. Important things, I don't see any fluid. I don't see any orange pigment or hemorrhages. And then you can think of things like RPE hamartomas that can be associated with familial adenomatous polyposis. You can think of other kind of congenital RPE hamartomas. And then those would be the main things. You can also think of, things like trauma. It certainly doesn't look typical for a scar, but you could ask about any prior trauma, prior surgery. It doesn't look typical for a laser scar, but certainly old laser can cause pigmentary changes like that. Those would be the main things I'd be thinking about.
Yeah, I think you're spot on. No pun intended there. Chirpy, and in particular, this morphology is characteristic of what is known as bear track. There are actually several different terms for this: congenital grouped pigmentation, multifocal chirpy, or bear tracks chirpy. As you mentioned, the RPE hamartomas that are classically associated with FAP, and then a couple of other pigmented lesions of the RPE remain on the differential.
Can I make a point? So the term you use here is RPE hamartomas with FAP. In the literature, it's called POFL, pigmented ocular fundus lesion, as labeled by Trabulsi, who's written a lot about this. So some people will call them POFLs, others will call them RPE hamartomas.
Great, thank you. I wanted, other than Dr. Carol Shields, other members of the audience, look, if you have a patient with this pattern of pigment change, what do you counsel them about? Anything special?
We get a lot of these referrals for please rule out Gardner syndrome, and from optometry, from PCPs, whenever they see bear tracks, they assume that there's an association, but I don't think there's an association between bear tracks and Gardner syndrome. There is between POFL or RPE hamartomas and Gardner's, but this is different. And so usually it's like you're diffusing the situation because everyone's very anxious. Am I correct, Dr. Shields?
You're spot on.
I should have just titled this case "Spot On."
Yeah, so we would do the same. We get referrals for this exact situation. Does this patient need to have colonoscopy? But when they're so round and there's no RPE loss and they don't show the features that you see with POFLs associated with FAP or Turcott syndrome. You had a case of Turcott syndrome on the retina service a year or two ago. Same thing. It's the RPE lesions associated with either FAP or Turcott's tend to have a fishtail, tend to have a very abnormal teardrop shape. So when they're round like this, we generally do nothing more.
Excellent. And that's the reason why I wanted to present this case, is there is a bit of a misconception out there, even among retina specialists, as to the significance of these lesions. Both Dr. Shields actually published a paper back in 2017 that really nicely goes over some of these pigmented lesions of the RPE and their significance or lack thereof. So talking about bear tracks or multifocal chirpy, as opposed to the hamartomas associated with FAP or POFL. The multifocal chirpy is a unilateral lesion. You do not see it in both eyes. It may be pigmented or apigmented, and this polar bear tracks term is sometimes used for the apigmented variety of it. it oftentimes has this sectoral distribution, and we saw even in our patient, there were kind of these radial sort of progressions of them in almost a sectoral distribution. And in the end, there is no association with an increased risk of colon cancer. And this is similar to an isolated chirpy or a more classic chirpy, which we normally counsel the patient positively, saying that reassurance is usually the order of the day. As opposed to the hamartomas, which are bilateral, they tend to be more randomly distributed, not sectorally distributed. They often have these ill-defined borders, and as Dr. Shields was saying, they have these irregular depigmented borders with either a comma, fishtail, or a comet sort of configuration to them. And interestingly, they are found in roughly 70% of FAP patients. Here are a couple of examples. On the left-hand side, you can see both classic chirpy and bear tracks. And we oftentimes think of chirpy as a fairly stable lesion, but that's not always the case. The panels C and D are an example of a chirpy that was actually found to expand over time. So these are lesions that still need to be monitored. And then on the right-hand side, you can see a couple of examples of these hamartomas or these pothole lesions. You can see that they're not as well-defined, they're not as deeply pigmented, they have these areas of hypopigmentation and almost in these sort of comma or fishtail morphologies. And again, they would typically be found bilaterally, not unilaterally. To just talk about a couple of the other pigmented lesions, I know it's a little bit of an alphabet soup for me when trying to think and keep track of all of these various pigmented lesions of the RPE. This on the left is a congenital simple hamartoma of the RPE. Again, it's thought to be migration of RPE cells. You can see this lesion is actually present in the inner retina, as opposed to a combined hamartoma of the retina and RPE, in which both RPE and retinal cells are involved. You can see this is a much more, much thicker lesion. There's a lot more distortion of the retinal architecture itself, but these are a couple of other entities that you need to keep in mind. So the takeaway for our patient here is she is not at an increased risk for colon cancer, and you can tell her that. In this case, she was already going to get an early colonoscopy, though, because her mother was found to have precancerous polyps. So she, I believe, patient was 40 years old. They were planning on doing an early colonoscopy for her. Any final thoughts about this?
No, the only point I would make is most of the patients that we have diagnosed with the hamartomas with FAP have been very young patients who come in or patients who already have a known history of FAP. The youngest in the literature was an 18-month-old that we actually saw here.
Wow.
It was published by Anu Ganesh, who's in Oman, but when she was a fellow with Alex Levin here, we published this case. 18-month-old sent in with pigmented lesions. We took a look. It looked like pothles. We got the genetic testing. It showed chromosome 5 abnormality. And we sent the patient to CHOP to get colonoscopy. And they said, no, go home.
Mm-hmm.
You're too young to have colonoscopy at 18 months. They typically wait until the child's 10 years old because that's when the risk increases. So they don't do colonoscopy on infants when they have FAP.
Very good, thank you. Our third case, I am actually going to take point on. This is a case that we presented a couple weeks back and weren't able to kind of fully complete. So I'm going to do a quick recap so we can at least all refresh our memories on what this case entailed, and then essentially go over some of the teaching points about this entity, which is important, I think, for us to be able to recognize because it's been fairly recently described in the literature. So this is, again, it's a 58-year-old male who is referred from the WER for increased floaters in the left eye. Unaffected right eye, 20/20 vision, though you can see these pigmentary abnormalities around the optic nerve, atrophic appearance, but also has just an atypical morphology for that that we usually expect to see with peripapillary atrophy. The left eye had similar peripapillary findings, but then also, in addition to this PVD and vitreous hemorrhage, as you can see from the central medial opacity, there's an inferotemporal large horseshoe tear, and there were several other tears not apparent on this photo in other quadrants. And then these multifocal whitish lesions of the posterior pole, mixed areas of confluent and speckled lesions that were not found in the right eye. Showing them in a little bit more detail, you can really see these multifocal whitish lesions. Here come some of the independent sort of multifocal appearance, and then near the disc you get more of this confluent change. The fundus autofluorescence of the right eye really better highlights these areas of peripapillary atrophy, some of which even have this sort of radial spoke configuration to them, and as we had discussed a couple weeks ago, almost looks like a nascent angioid streak. And in the left eye, again, we have a little bit better defined areas of hypoautofluorescence radially spoking off the disc, looking a little bit more like angioid streaks. You see a little bit of some blockage from the mediopacity, some pigment change infratemporally in the area of the tear. But then really the important finding that I wanted to highlight here are these areas of confluent and speckled hyper-autofluorescent signal predominantly in the posterior pole. The OCT of the right eye, again, 20/20 vision, there was a little bit of some atypical choroidal architecture here with thinning nasally. We see a little bit of the peripapillary atrophy and loss of the outer retinal layers just directly adjacent to the nerve. But otherwise, no PVD in this eye and a relatively normal appearing inner and outer retinal lamination patterns. And then in the left eye, again, degraded signal from some of the mediopacity, the inner retina with fairly normal morphology. Though you can see as you get to the, again, nasally towards the optic disc, you have these areas of atrophy, hyper-transmission of the signal into the choroid. Again, this kind of strange sort of thinning of the choroid nasally with much more prominent and thick choroid centrally and temporally. And you can see some of these irregularities to the RPE, kind of a lumpy, bumpy appearance, and some disruption of the ellipsoid zone, which looks not atypical of what we oftentimes see in angioid streak patients. And then just to look a little bit more superiorly through some of those hyperautofluorescent lesions and hypopigmented lesions on the pseudocolor, you can see these disruptions here in the outer retina, predominantly involving the ellipsoid zone, even some distortion here in the external limiting membrane. Almost looks like there might be even some excrescences in these areas correlating to those hypopigmented lesions. Here is a IVFA image of the right eye at 31 seconds. You can see early window defect correlating to these areas of peripapillary atrophy. And a little bit later on, you can see that there is overall well-preserved vasculature filling of the vasculature, though infratemporally there's a couple of microaneurysms and some capillary non-perfusion. It should be noted that there were intraretinal hemorrhages noted in this area on fundus exam that did not appear on the pseudocolor. And then in the left eye, you can see, again, window defect correlating to these angioid streaks, and then a much more prominent early hyperfluorescent signal correlating to these hypopigmented lesions, though we don't see any signs, at least at this point, that this is early leakage, was felt to be staining. And then a late frame in the right eye, again, continues to show these little microvascular abnormalities and microaneurysms, but no leakage, no signs of any vascular leakage or choroidal neovascularization. And then a late frame of the left eye, again, shows persistence of this hyperfluorescent signal of the posterior pole. Again, I felt it would be reasonable to call this staining given this time course. And then these window defects remain unchanged. The slit lamp exam was overall unremarkable aside from pseudophakic in both eyes and had 1+ white blood cells in the vitreous on the left only. So we kind of talked, there's a lot going on in this patient and can probably be broken down into 3 differentials. In the left eye, which is the one that had those hypopigmented lesions, we were talking about how this could be a MUDES or an epiMUDES, that is MUDES secondary to some other retinal insult, but other white dot syndromes would need to be considered, such as AMPI, multifocal choroiditis, azor, and then infectious causes like syphilis can sometimes cause this sort of an appearance. The right eye with these microvascular abnormalities and hemorrhages, we're thinking focal peripheral BRVO, hypertensive retinopathy, NPDR, radiation retinopathy, fever, and Eales disease would be on the differential, though patient had a negative medical history for any of the conditions, including hypertension, is not even on medication for hypertension at this time. And then there's the question of these findings of peripapillary change, angioid streaks in both eyes, which raises a very specific differential diagnosis for us as well, including pathologic myopia, PXE or Ehlers-Danlos, hemochromatosis, thalassemia, Paget's, homocystinuria, Marfan's, and acromegaly. So for our patient's medical history, like I said, he's overall very healthy. He does use an Advair inhaler for asthma. There's no known personal family history of connective tissue disease, and that close inspection of the skin of his arms and his neck did not have any of the chicken skin findings. He did have cataract surgery several years before, which was uncomplicated, and his axial length is high in both eyes. Again, we check that because we don't have an accurate pre-op refraction for him. You can see axial length of nearly 26 millimeters in each eye. And his blood pressure measured in our emergency department was 118/78. The patient said this is fairly typical for him, and he's not on medications. So the next steps that we did for this patient, obviously we treated the tears from the acute PVD and put him on vitreous hemorrhage precautions. We did order a laboratory workup, including syphilis, CBC, hemoglobin electrophoresis, specifically looking for thalassemia in this case, and then iron and ferritin studies looking for hemochromatosis. And then we have actually sent genetic testing for ABCC6, and that's to kind of get at what could be the potential cause of those bilateral peripapillary findings. But what I'd like to discuss and kind of bring home for you all is this phenomenon of epimudes. It's been recently described in the literature and is something that is becoming more and more recognized as we get especially autofluorescent imaging on more and more patients. It is in contrast with a primary mudes, which is typically of idiopathic origin. We don't know exactly what causes it. But epimudes is associated with underlying retinal insult, and it's oftentimes an outer retinal insult. There's this term, the tunica ruschiana, which is the layer of the eye consisting of the choriocapillaris, the Brooks membrane, and the RPE, and it's felt that there's disruption of this layer may be one of the precipitating factors that may result in this mudes-like reaction. The preponderance of cases in the literature have actually been reported specifically in cases of multifocal choroiditis, which obviously has outer retinal disruption. We see the chorioretinal inflammation and scarring. It's also frequently reported in cases of CNV, and it often has a similar course to that of primary mudes, that is, it's self-limited and usually will spontaneously resolve, though can occur in particular, reoccur, particularly if the retinal insult is one that may continue to reoccur as well. One of the kind of pivotal papers or series that's been published came from Ciccinelli and colleagues back in 2021 and described 4 cases of an acute epimudes-like response. Patient 1 here had acute multifocal choroiditis and exhibited these hyperfluorescent lesions consistent with a mudes-like pattern. Patient 2 had more of a Best disease type phenotype, but also had these, again, punched out inferior peripheral choroidal lesions, almost looked kind of like a multifocal sort of phenotype, and also showed these hyperfluorescent lesions on FA. Patient 3 actually had a laser-treated CNV lesion in the macula, and then the nasally, again, some atrophic choroidal lesions with associated mudes-like hypopigmented spots. And then this 4th patient had some inferior pigmented punched out lesions. And again, you can see this multifocal speckled hyperfluorescent pattern here in the macula and posterior pole. Mudes-like retinopathy has actually been described in pseudoxanthoma elasticum, and we know that that condition features prominently on our potential differential here. In fact, a series was published that showed that 9 out of 167 patients with PXE developed an acute outer retinopathy that had mudes-like features. Interestingly, none of these cases reported a concurrent insult like an acute PVD or horseshoe tear as we saw in our patient. There are other masqueraders, though, of epimudes or mudes that need to be considered. Infectious conditions like syphilis, classically a bilateral mudes presentation, needs to prompt a syphilis workup. Primary vitreoretinal lymphoma can have these hypopigmented lesions that have some hyper autofluorescence signal. Idiopathic retinal phlebitis and cancer-associated retinopathy have also been described, as well as azor. And it's also been seen in association with the use of checkpoint inhibitors. So in addition to the subretinal fluid that has been described that we can sometimes see with use of checkpoint inhibitors, patients have also been shown to have a multifocal white dot syndrome-like appearance as well. And then not to forget about COVID, which is ever present. It's also been described 2 weeks following vaccination with the Sinovac coronavac. This was a young female. This was the whole inactivated virus form of the corona vaccine. A little unclear if this is true causation versus correlation. As we know, young females are predisposed to develop mutes as it is. So unclear if this was indeed temporally associated with the vaccine, but it has been reported. So just a brief discussion, because we do have a fourth case we want to get to. What do we think was the underlying cause of this mutes-like reaction in our patient? Was the PVD with tears relevant here? Was it just these underlying angioid streaks as has been described in PXE patients? Were both of these insults required, or is there an alternate as yet unidentified posterior uveitis? My thought was both might be required. We don't normally see these reactions in acute PVDs, and maybe the association of this acute insults with the underlying angioid streaks were necessary.
I don't think you'll know. I think you're probably right. It could be either of those. I'm not crazy about the term epimudes, particularly when you look at things like syphilis, because syphilis is not an evanescent disease. It's not going to get better on its own. So I think it's a misnomer in that regard, as opposed to the classic mudes presentation, which will spontaneously regress.
Yeah, I think there's also this question of the epimudes versus mudes masqueraders. And I think that hasn't been totally sussed out yet. But even as I was putting this presentation together, some of these entities seemed to be more of an epimude. Some of them seem to be more of a masquerader.
Yeah, there's always a tendency when something new is described for everything else that follows that to be a variant of that new presentation.
Right.
I remember when I was an intern, there was a case of something called diffuse idiopathic skeletal hyperostosis presented at one of the internal medicine grand rounds. And it's a very rare disease. And radiology staff said you have to stop ordering testing on these patients, because after that grand rounds, they had like hundreds and hundreds and hundreds of patients referred for DISH, based, Right. Based on a minor abnormality on an otherwise normal chest X-ray. So I think we have this tendency to say, well, this is, epimudes or mudes variant, as opposed to thinking, is this really a totally different disease?
Yeah.
Because we're making that diagnosis of mudes really just based on the imaging.
Great, thank you. So in the interest of time, Dr. Benson, do you have a final comment?
One thing.
Yeah.
Since pseudoxanthoma is the leading cause of angioid streaks, checking out the skin is not enough. If you really wanted to diagnose, you have to do a scar biopsy.
Yeah, very good. And we do have genetic testing pending on him, so we're looking forward to seeing the results there. So our final case is a patient referred for really dense vitreous opacities in the left eye. And Dr. Polito, I was hoping you might be able to describe what's going on here.
Oh dear, this is problematic.
Poor prognosis, I know.
So I think we can go backwards and say this probably used to be some larvae that have grown to be beautiful monarch butterflies that are coming out of the eye and have done amazingly well in medical retina.
Do you guys want to come up? So this is our final imaging conference of the year. Just wanted to thank everyone who comes and tunes in. We hope you've learned something. We certainly have. I mean, doing these case presentations definitely helps us learn medical retina. And we sincerely appreciate all the input. Specifically, we want to call out a few names, Drs. Sivalingam, Polito, and Kurian, who take on the leadership role putting together this conference for us. Obviously, both Dr. Carroll and Dr. Jerry Shields, who always contribute some excellent input with regards to neoplastic conditions. Dr. Dunn, our uveitis specialist, who always deepens the conversation, especially with the multiple variants of syphilis that we presented this year. And then some of the Mid-Atlantic retina surgeons, Drs. Regillo, Park, Gupta, Garg, Yonakawa, and Dr. Benson, for always being here on the regular basis and contributing your knowledge and input. And then finally, as was mentioned before, Jack Scully and Bill Romano, without whom we could not successfully put on these presentations and broadcast them to the world. Thanks for making us look good. And I think just on behalf of all of us, we just want to thank you all for teaching us, and we look forward to starting up again with a new crop in September. Thank you.